Hello, I'm Salim Varani from Baylor College of Medicine, and I'm joined today by my two colleagues, Dr. Aaron Mikos from Johns Hopkins School of Medicine and Dr. Donna Arnett from the University of Kentucky College of Public Health. We were all involved in the development of the updated ACC/AHA guidelines on primary prevention of cardiovascular disease, and we're discussing that today for our clinicians who are in internal medicine and family practice. So, Dr. Arnett, can you start by explaining us which segment does this guideline apply to?
So this guideline is primarily intended for all adults in the US for primary prevention of cardiovascular disease. So essentially it's everyone who has not had an overt cardiovascular event. This is to whom that guideline applies.
Nice. And then in what cardiovascular events, Dr. Mikos, are we talking about when we talk about
Right.
cardiovascular disease?
So not only are we trying to prevent atherosclerotic cardiovascular disease, so coronary heart disease events and strokes, but these guidelines also emphasize the prevention of heart failure and atrial fibrillation for a more global prevention approach.
Perfect. So let's start out with some lifestyle factors. So what are some of the key messages for our clinicians if they want to impart changes related to diet or physical activity for the patients?
So interestingly, as you know, 80% of cardiovascular disease is preventable, and it's preventable through these lifestyle measures. So our diet recommendations emphasize a diet that's rich in fruits, vegetables, legumes, nuts, and fish, and whole grains as a baseline diet for everyone to follow. Limit the amount of red meat, limit the amount of processed meats, as well as limit sodium and cholesterol intake itself. So those are the major components of our diet recommendation. Interestingly, we have for the first time a harm recommendation around trans fats. So we should eliminate trans fats from our diet.
And what about physical activity recommendations? Have they changed or they're the same?
So the physical activity recommendations are the same, which is 150 minutes of moderate physical activity per week. And that moderate means a brisk walk, for example, or 75 minutes of vigorous activity a week. And that is things like jogging or swimming. The one addition that we've made is that we want to emphasize that activity is important. You know, we don't want our patients to think they have to exercise or go to a gym or restrict their activities to those kind of things. We want them to be more active. So if they can't meet those recommendations of 150 or 75 minutes, do something, because every little bit of movement away from the couch is shown to be beneficial.
Perfect. That curvilinear association that even increasing your physical activity by 10 to 15 minutes actually has a lot of benefits, at least when we look at coronary heart disease events. So that's perfect. And anything on sedentary behavior that the clinicians should be aware of?
So we do have a recommendation that it may be reasonable to not be sedentary. You know, there's some early indications that standing may be of benefit. So we do have a recommendation about that. I think as the evidence grows, that level of evidence and recommendation will grow stronger.
Perfect. So moving on to you, Dr. Mikos, can you summarize some of the recommendations related to management of major risk factors or disease conditions like diabetes, hypertension, cholesterol? How do we start out when we see a patient in the clinic? What's the first step that we should do?
Right. So you already heard from Dr. Arnett that lifestyle is still the foundation of prevention. But when we start thinking about drug therapy, it's important to estimate one's absolute risk. And we do this using those pooled cohort equations to get a 10-year risk. And the reason why we calculate this is we want to maximize anticipated benefit of any drug therapy, but minimize harm from overtreatment. So, you know, when it comes to cholesterol, so we would calculate that 10-year risk. Note that individuals with diabetes and LDL cholesterol greater than 190, you don't need to do the risk assessment. You would just treat with a statin. And among individuals who are above the 20% 10-year risk, we would treat with the statins. But for individuals that are borderline or intermediate risk, often risk is uncertain, and so we want to consider risk-enhancing factors. These are clinically available factors that were outlined in the cholesterol guidelines. And then after we consider those factors, if risk is still uncertain and we're on the fence about whether to start a statin or not, a coronary calcium score can be a tiebreaker to help guide decisions about statins, such that Individuals with a calcium score of 0 might be at sufficiently low enough risk where statins could be postponed or deferred if that's what the patient wishes. On the other hand, those with coronary calcium scores of greater than 100, we generally recommend statin therapy. So we take that 10-year risk estimate, also carries through the blood pressure guidelines, if you remember. So that individuals who have blood pressures above 130/80, but are also at elevated risk, above the 10% 10-year risk, then we generally recommend pharmacological therapy on top of lifestyle, which of course is the foundation. But individuals who have a lower risk, less than 10% 10-year risk, then so we don't consider drug therapy until the blood pressures are above 140/90 consistently. Now, interestingly, for aspirin, though, we actually don't use that risk calculator to make decisions about aspirin. Actually, what's new about these guidelines is based on those recent trials in the past year. Aspirin has taken a de-emphasis where we've said generally know that most healthy adults who don't have established cardiovascular disease, most of them don't need aspirin for primary prevention. But there may be a select few, and that's where a few patients that might still benefit because they're at high enough cardiovascular risk, and that requires a discussion with their doctors. So generally, no, sometimes yes. But we also, for aspirin, have some harm statements in. So one of the pivotal trials last year was the Esprit trial of aspirin in older adults for primary prevention that not only didn't show a benefit, but showed harm of bleeding and increased risk of death. And so because of that, we had a class 3 recommendation that says don't use aspirin in adults over the age of 70. And we also said don't use aspirin in adults of any age who are at increased risk for bleeding. And then diabetes, we again emphasize lifestyle, we emphasize the statin. And then for medications, so after lifestyle is not enough, then when we're talking about glucose-lowering drugs, metformin's the first line. And then it may be considered to use some of those newer classes of medications, the SGLT2 inhibitors and the GLP-1 receptor agonists, which have been mostly used in secondary prevention, but emerging evidence have shown some support for primary prevention. So we gave it a 2B, may be considered for primary prevention. And that recommendation may get stronger in the future as we get more data on this new class of medications.
Perfect. That was a very good summary. And the treatment target for blood pressure remains, once treatment starts, is less than 130 and less than 80 for the diastolic.
Yes, I should.
Perfect. That was, and I would remind our viewers that actually there are some other broadcasts available for both the hypertension guidelines as well as the cholesterol guidelines, that if you want to get more details, you can refer to those. So the other aspect of this guideline that is extremely important, and there's a lot of effort that's gone into is the concept of social determinants of health and making it a team sport. So what can the clinicians take as some of the messages out of those sections of the guideline?
So we had 3 specific recommendations that were overarching that really transcend all of our recommendations that you've heard about with diet all the way up through aspirin use. The first is that a team-based approach to primary prevention of cardiovascular disease is really essential. There's a lot of pressure on the physician to do everything, and really having a team that could help us with recommendations for diet or physical activity could be helpful. The second is that the patient should be at the center of all of these discussions and be working with the physician to make sure that they're making decisions together. That improves adherence, and it, I think, improves the outcome for the patient. And then finally, social determinants. You know, we have known for a long time how to prevent cardiovascular disease, and as you know, we're not doing a great job in our population. The real reason, I think, is because we are not meeting patients where they are. We tell them to eat a healthy diet. Do we know whether or not they can afford fresh fruits and vegetables, or even have access to fresh fruits and vegetables if they live in the inner city? We recommend that they get physically active. Well, do they have a safe neighborhood that they can be active in? So we're asking in every one of these domains to be asking the patient, before making recommendations about these issues.
Perfect. So looks like it's very comprehensive. There's a lot of topics that have been covered, but we have to look at the context a little bit more as well when we're giving these recommendations and discussing these with our patients. So this has been a great discussion. Dr. Arnett and Dr. Mikos, what would be the 2 or 3 key takeaways that clinicians should remember from this guideline? We can start with you, Dr. Arnett.
Well, I'll start with where I just ended. addressing the social determinants of health in our patients will allow us to create and tailor interventions for primary prevention specific to those patients.
Perfect. And how about you?
Right. So I agree with it's just as important to realize that social inequalities are a key determinant of cardiovascular risk, and we have to address that. And then I want to emphasize again the shared decision-making approach. So essentially, we have the scientific evidence from the trials that form the basis of the guidelines. Then we have our clinical judgment about the patient that's sitting in front of us. And then we have to take in patient preferences and values and meet the patient where they're at. And so it's the intersection of these three spheres that really has these guidelines emphasize a patient-centered approach to comprehensive primary prevention.
Perfect. This has been a great discussion. I thank you both for your time and to our viewers. Thank you.